Next to me, Professor Jo Baxter is the Associate Dean Maori at the Kaatu Centre for Haora Maori at the University of Otago. Her talk will focus on understanding key issues for Maori in the COVID-19 policy and health response.
Kia ora koutou, tēnā koutou, kia koutou, kua hui mai nei tēnei rā. Ko Jo Baxter tōku ingoa, kei te urio no Pautini Kaitahu, ko Kati Maha ki te hapu, me no Ngāti Apa ki tērā tō, ko Kuaha o te rangi te hapu. Ka nui aku mihi ki a koutou katoa. I want to thank you, Phil, for inviting me to contribute to this series of talks and to have the opportunity to provide a background focus on Māori and COVID. My name is Jo Baxter and I'm Professor of Māori Health in the Otago Medical School, and I'm also a public health medicine physician. My academic and professional journey have focused on issues of equity and Māori outcomes, including mental health and suicide, Māori child health inequities, Māori tertiary education and equity, and Māori health workforce. With regards to COVID, I currently sit on a recently established Ministry of Health COVID-19 Māori monitoring group and have been part of a reference group to the Ministry of Health. So the position I take in speaking to you today is one that foregrounds the COVID response to Māori within a te reti o Waitangi and equity frameworks. The time for this talk is brief, and as such, this talk takes a wide sweep over the context and response within Aotearoa me te Waipounamu to COVID-19 and Māori. In that sweep, the focus is on issues of equity, and we'll dip into some critical contexts, outline some key aspects of government and health sector response, and take a look at Māori responses, actions and aspirations, finally exploring where to from here. A range of sources of information have fed into this talk, and given the brevity of it, it's not possible to go into depth in relation to those sources. However, all are referenced on the slides, so you can seek out more information if you wish. It's fitting to position the Māori experience in response to the COVID-19 pandemic with cognizance and respect for a number of critical contexts, including historical, political, societal, and health contexts. History speaks of a tragic picture of the disproportionate impact that previous pandemics have had on Māori, as evidenced by the 1913 smallpox pandemic, followed by the 1918 influenza pandemics, which caused devastation for Māori whānau and communities. Data suggests that about 4 to 5% of the Māori population died in the 1918 influenza pandemic, with rates that were between 7 to 8 times higher than non-Māori New Zealanders. Marked inequities in mortality were also experienced in the 1957 pandemic, and more recently during the H1N1 influenza pandemic of 2009, where rates of influenza were twice as high for Māori compared with Pākehā, and Māori were also 3 times more likely to be hospitalised and almost 3 times more likely to die than Pākehā. The legacy of early pandemics and inequities in other infectious diseases and other health conditions has resulted in a Māori population that is primed to be very, very, very wary of this pandemic. Aware not only of the impacts of such an event, however, the need to take urgent and extreme action in order to protect Māori communities and the most precious and vulnerable within those communities, particularly our elderly. Dr. Rhys Jones, in an article on March 18th, explored further why Māori appear to be at greater risk for pandemics. He talked about different factors at play, including underlying social and economic disadvantage as a result of historical and contemporary colonisation. He talked about a greater burden of chronic diseases that increase the risk of more serious outcomes from infections such as influenza, and also more poor access to quality of health care. Dr. Jones joined many others, and you can see multiple interviews, reports, and articles making calls in relation to our COVID response to ensure an equity lens is applied to New Zealand's response. Maori health experts expressed genuine concern that taking a one-size-fits-all approach may not be as effective for Māori and that inequalities would result. Evidence for increased risk has been held out by researchers from Te Pūnaha Matatini, the University of Canterbury, University of Auckland, and Manaki Whenua, who've used modelling to predict risk of infection, taking into account such risk factors including healthcare and comorbidity. During the course of the pandemic, their modelled estimates across various age groups show Māori and Pacifica populations would have a higher infection fatality rate in comparison to European populations and other groups in New Zealand. Modelling shows that because of underlying health conditions, socioeconomic disadvantage and structural racism, the death rate for COVID-19 could be as much as 2.5 times higher for Māori. Concern over increased risk is further reinforced by international evidence where marked inequities are already being reported for population groups who experience marginalisation and oppression. With USA and UK both showing socioeconomically disadvantaged groups, people of colour, and those who work in the front line all at increased risk, with considerable intersectionality among these risk factors contributing to inequities. It is noted that the Navajo Nation in the USA has the highest per capita caseload in the USA. So how have we responded as a nation, and what does our policy look like? So New Zealand's COVID-19 Health and Disability System Response Plan is certainly worth anyone who's interested in what we're doing in relation to COVID worth looking at. And within that plan, there is a very clear set of statements. One of them relates to a commitment to Te Tiriti o Waitangi, and it does highlight Māori as a priority population group and recognises increased susceptibility. There is recognition that previous pandemic responses have in fact failed to ensure equity, and the plan explicitly states equity and active protection as part of the plan. The plan goes on to draw on the principles that were outlined in the Y2575 Te Tiriti o Waitangi claim for Māori health, which reinforced equity, tino rangatiratanga, protection, and in addition incorporates the provision of options for services and the importance of partnership. These principles are reinforced across a number of other documents, and they seem to have become a really clear platform, both for ensuring that we prioritise equity, but that also for Māori we take into account the very key requirement to support Māori to have tino rangatiratanga as part of the response. In April, the Ministry of Health released a Maori Response action plan as a living document that aimed to focus on strategies for Māori in recognition that the pandemic phase has changed, then the plan would need to adapt. It foregrounded the principles talked about previously in the overall plan, as well as 4 expressions of the treaty: manu whakahaere, mana motuhake, mana tangata, and mana Māori. These 4 goals encompass stewardship, Māori self-determination, equity of outcomes, and respecting and enabling te ao Māori. And I'm not going to go through this diagram, but if you look at the report, you will see how these principles are converted into actions in the report. In order to support the response to Māori, alongside the funding that came to all services, the whole of government response to funding, a specific amount of $56.5 million was provided to focus on Māori support and response to the COVID breakdown. And this includes $30 million specifically for health, as well as other funding to support whānau ora and community outreach. The kind of health funding that was provided was spread across specific areas, including resources for whānau, bolstering Māori health providers and whānau ora services, and a range of others, including community-based assessment centres in Māori communities, development of communications and health literacy resources, telehealth support, and very importantly, increasing access for Māori to influenza vaccinations. What we know and what we have gathered through the reports from people who have been part of the great mobilisation to deliver services has been that the funding has been critical to the widespread mobilisation and grassroots service development and responses across many Māori communities, organisations and whānau. And it is an example that many people are now looking at for how we can utilise approaches to directly supporting Māori mobilisation to deliver health services. So the Maori response, when we look at that, has been characterised by taking an equity lens with a high degree of commitment and adaptation. It's been very value-centred. There's been lots of examples of innovation and resourcefulness, solutions-focused and strengths-focused, with many examples of collaborations and partnerships, groups coming together with a real commitment to making a difference for Māori. And I've identified here a whole range of areas where this has happened: building collaborations, protecting Māori communities, providing advice, advocacy and influence, adjusting and working with and adapting tikanga and cultural practices and responsiveness to Te Ao Māori, working with data and information monitoring, mobilising Māori services, including whānau ora and iwi hapu and whānau, development of resources and health information, health literacy, and influencing wider economic, business and employment policy and strategy. So a huge mobilisation of Māori throughout Motu. When we look at some very specifics about testing, and this is between 22nd of January to 27th of May, we see that Māori were tested at a slightly higher rate than non-Māori on average. On the 24th of April, the Ministry of Health told DHBs to ensure their testing was covering off Māori. And in some places, iwi health providers quickly started bolstering their efforts to test Māori. In Taranaki and Tairāwhiti, mobile clinics were ramped up in isolated places. And between 18th and 30th of April, the Māori testing rate per 1,000 people jumped. The academic Rawiri Taunui, who'd been tracking numbers closely, reported a marked increase, which he believed that getting Māori health providers involved was key. COVID-19 test positivity rates by DHB and ethnicity were part of the data that was being collected, and I won't go through this slide, but what it shows is overall 0.2% of Māori and Pacific people who were tested were found to be positive, and 0.5% of Asian and others. And I've just got in yellow the Southern DHB, where we see something a little bit different, which is 1.2% of Māori who were tested were positive. So lots of capacity to look at data and to try and identify where areas of equity could be addressed. And that has been a really important part. So overall, when we look at our total cases, we see that compared to other pandemics, so far Māori have fared well in terms of cases, with only 9% of total cases currently reported being Māori. So this concept of protection that has been highlighted, and learnings from 100 years ago provided Māori with important information about ways in which we can protect communities, with historical accounts in early pandemics of Māori communities closing their borders, reducing access, and even entire communities packing up and moving in order to provide protection. Encompass strategies to support wellbeing and livelihoods of those impacted by pandemics, devastation, and the role of leadership in protecting Māori communities has been critical. So even though we were able to look to the leadership of people going back 100 years, many of the same sentiments and the desires to provide protection were also of real relevance today. And you will all be aware through the media, and some very interesting media are reporting about the decision from a number of Māori communities to close down their access to their communities and to provide roadblocks and check-in points. And it's not surprising that early on Māori communities chose to introduce these roadblocks and checkpoints. The legacy of such a great loss 100 years earlier was at the forefront of people's minds. Māori-led roadblocks and checkpoints became a core feature of the Maori response in a number of regions. These roadblocks sought to achieve what we as a country have been seeking to achieve with our border closures. And it's the main purpose to protect our populations. In addition to roadblocks, these roadblocks have involved many positives, including providing a point where people who are passing are offered advice and wellbeing services, they're checked in on and are able to make links with healthcare and other services. These aspects were much less well reported in the media. A further focus of protection alongside whole communities has been the desire by Māori to protect the most vulnerable people, including mobilisation to protect elderly, those people with chronic health issues, and people with disabilities. Calls for an equity lens were made by many health leaders and health experts across the country, and over the past 3 months, these numerous articles and interviews all highlight the need for our responses to engage heavily with Māori. A particular group, Te Rōpū Whakakaupapa Uruta, is a group of Māori health leaders and experts who are very concerned about the lack of presence of Māori in the response to the COVID-19 pandemic in its early days, and became heavily engaged in providing information, shaping response to equity, providing a public voice and expertise, and most importantly, creating a platform for conversations and for information, resources, advocacy, leadership and input. Māori approach to messaging has been strengths-based and mana enhancing, whereas in the past and for many health issues, it is very difficult to have a platform of information that's focused specifically on Māori. The resourcing and the support for Māori development of resources has meant that there is now a wide range of resources tailored to diverse aspects of the community. The Pūtahitanga Māori Whānau Ora Māori Commissioning Agency for the South Island coined the term Manaaki 20, converting COVID-19 to something that they saw as much more strengths-based. Organisations such as the Whānau Ora Commissioning Agencies have undertaken a whole range of individual as well as group and whānau supports, and there's a lot of data and information about the kinds of activities they have been undertaking. So when we look at this response, we see growth of Māori health providers, community-based assessment centres, and very importantly also increase in Māori taking up influenza vaccinations, including social media campaigns, public health and social sector supports. And I think there is a lot of belief among people delivering these services that they're feeling like, despite this being a time of high stress and high needs among Māori communities, the mobilisation of supports and services has greatly impacted upon very positively those Māori communities. Cultural responsiveness has been seen in all sorts of places, including the development of new terms and language to fit with the epidemic and the pandemic, and the response to cultural practices, including the use of marae and tangihanga, have been ongoing and difficult part of the lockdown. Māori have taken on board the various requirements over tangihanga at each phase of the lockdown. However, this has been difficult for many. In some commentary, tangihanga, the ability to farewell a loved one, is a core part of Māori society and well-being. Level 4 restrictions were rigid and devalued the importance of Māori cultural practices, according to some commentators. So others have spoken about the need to sacrifice these rights and a number of solutions were raised, including holding off tangi until after lockdown and utilising tangi. Just thinking more broadly, the role of services, iwi and others have provided a range of community based responsiveness across many regions and communities, meeting the needs of many Māori and whānau. In an April paper, Kukutai et al. State that over the past month, iwi and Māori communities have demonstrated a remarkable capacity to anticipate and respond to the needs of their people. From setting up checkpoints to protect vulnerable and remote communities, to providing online support for grieving whānau, and delivering care packages to elders, Indigenous communities in Aotearoa and elsewhere demonstrate powerful distributed leadership and a deep capacity to care for each other based on the strength and knowledge of kin and kin-like connections. So other people have also focused on the fact that we have learnt much, and Dion Tuta highlights Māori will emerge from this stronger and more connected because of our focus on protecting people. He goes on to talk about the strength of Māori resilience through unity and relationships. However, we need to hold that thought as some predict the impacts will hit Māori hard. In every recession, Māori have been impacted more than other ethnic groups. Māori currently already have a baseline unemployment rate of 8.2%. The Māori Council highlighted that as we head into recovery phase, we have many additional challenges. So it is indeed timely to reflect on what we have learned about the Māori response, how well tino rangatiratanga is reflected, and importantly, how well are we tracking to ensure equity as a priority for outcomes in relation to the COVID response is indeed realised. How do we take into account the upcoming challenges in relation to socioeconomic and wider determinants? Commentators are in agreement that in order to not accentuate inequities at this point, some very important pro-equity strategies are required in the whole of government approach and in the approaches taken in each sector, including health, education, and employment. It seems very clear that unless we move together to actively reject increasing inequity as an acceptable outcome of the COVID-19 pandemic, our gaze and our national response thus needs to go to how we can build a future that honours Te Tiriti Waitangi and acts to address historical, current and future inequity. This is indeed timely as we live in a time where we have the outcomes of the Y2575 claim reinforcing key principles and tino rangatiratanga. We have the Health and Disability Sector Review, which includes at around page 174 an approach to build on the positive outcomes achieved as part of Māori-led mobilisation of partnerships, services and culturally responsive approaches. Nō reira, tēnā koutou, kia ora no tātou katoa.
Thank you, Joanne. We have two questions that have come through so far, and I will read them as they've come through. Infection rates of Maori and Pacific Islanders were approximately 6%, whereas that of Europeans and Asians 9 to 10%. Do you have a view about these differences?
I think if we look at the cases that we had, and Phil may also have an indication of this, many of the cases we had direct links to overseas travel or contacts with overseas travel. And so I think there was probably very much an ethnicity association with that. And then the other key areas were areas such as the clusters that occurred in rest homes. And again, there are some differences in terms of the ethnic makeup of people who end up in rest home care. So I think it's a cluster related issue, but also and it's also a positive picture in terms of the fact that we didn't have the level of community spread that would have potentially meant that those people who are most vulnerable are likely to end up being most impacted.
Okay, thank you. Another question here. Do you think Maori language and concepts, for example, rahui, could be more prominent in the whole of New Zealand in the government's approach instead of something that is specific to Maori communities?
I think actually the word rahui has come up as, like many other Māori terms and words, once they enter an understanding such as concepts such as whānau, whanaungatanga, the concept of rahui is one that ultimately is one of protection and positivity. So I would envisage that it would become something taken up more.
And what is your view on the way the government has thus far engaged with Maori in the national COVID-19 response?
I think, I suppose I've got a mixed view in that I think it took a bit of time for people to fully engage, but overall, I think we're actually sitting at a point, a knife edge, I think, would be the way that I see it, and that we've got to a certain point where there's been funding, resources, policy development, which has allowed us to start to get some positive outcomes, including outcomes from the Maori Response. And I think where we go from here will help us fully understand how well the government has responded. And I think that really sits in terms of how the government responds to things like the health and disability sector review and the calls for Māori to take leadership and to gain more ownership of aspects of health service delivery and commissioning, such like.
Thank you, Joanne. I'm going to wait a few seconds in case anybody else has any questions they'd like to type into the Q&A. We don't have an enormous amount of time, obviously, in our webinars due to the tight schedule, but if you do have any questions, please do type them in. Nothing seems to be coming through, so I'd like to thank you very much, Joanne. If anything does come through, we will email more to you and you can answer in writing. Thank you very much. And on to our next presenter,